right, good afternoon, everyone, and welcome to today's program on the CMS FY 2022 IPPS proposed rule, where we'll highlight the critical changes that will impact donation and transplantation moving forward. My name is Deanna Fenton, Program Manager here at the Alliance, and it's my pleasure to host and moderate today's discussion. Now, our goal for today is to neutrally educate the donation and transplantation community on the CMS final rule in advance of the pending deadline for public comment. But before we go ahead and get started, and before I introduce our panel, I'd like to welcome Carrie Hobson-Pape, Executive Director of the Alliance, to share a few words. Carrie?
Great, thank you, Deanna. As Deanna mentioned, my name is Carrie, and I have the honor to serve as the Executive Director of the Alliance. We'd like to extend a special thank you to Jennifer Milton and Brigitte Sullivan for bringing this important topic to our attention a few weeks ago and recommending this program today. We always welcome emerging topics that are important to our community, so we encourage each of you to share your recommendations for learning programs in the future. In addition, the Alliance does not take a position on issues and always intends to maintain a balanced and objective perspective while bringing critical topics to the community for important discussion. Finally, all of the material shared today will be posted after the program to the Community Resource Toolbox on our website, which is organdonationalliance.org under Resources. And we will be sending an email to each of you after this event. So with that, I will pass this back to Deanna to kick off the program.
All right, thank you, Carrie. So for those of you who may be joining us for the very first time today, we do ask that you take note of the Q&A feature that's located in your Zoom navigation bar at the very bottom of your screen. All of your questions for our presenters should be submitted here. Now, we do realize that we received a number of questions from some of you during the registration process. So please know that we've done our best to compile your questions and we'll address them throughout the course of today's presentation. But should you have any additional questions, please feel free to submit them in that Q&A box. Once the presentation has concluded, we'll go ahead and transition to our formal Q&A discussion, where our presenters will address as many of your questions as time allows. Additionally, for those of you who are joining us as a group, please take note of the following poll. If you're using this program as a group learning opportunity, we ask that you complete the poll to indicate approximately how many people have joined your group. Your responses will ultimately help us and our presenters gauge the level of participation and engagement in today's program. Now, for anyone interested in our upcoming programs, please take note that registration is still open for our next donation-focused webinar, which will highlight effective strategies for physician engagement. So be sure to join us for that tomorrow, June 15th at 2 p.m. Eastern. Additionally, registration is open for our next transplant-focused webinar entitled What's on the Horizon? And in that webinar, we'll highlight the new PHS guidelines and multi-organ transplants. So be sure to tune in for that on Tuesday, June 29th at 3 p.m. Eastern. Now, to learn more about any of these programs or our future programs and ensuring you have the latest information, please visit our website at organdonationalliance.org. Now, given that this is a great learning opportunity for the community, we are offering continuing education credits for today's program. That said, please note there will be one nursing contact hour and one CET-C credit available for your participation in today's discussion. For those of you who are not seeking CEs or maybe seeking CEs that are not being offered, please feel free to claim the certificate of attendance instead. Everyone joining us today is eligible to claim any of these credits mentioned. Prior to receiving your credit, however, you will be asked to complete a brief online evaluation. We do ask that you complete these evaluations to provide us with your thoughts, as it's ultimately your feedback that will help us develop future programs like this for our community. If you happen to be listening in a group, please be sure to get that evaluation email from your group lead. As a friendly reminder, you'll have 30 calendar days to complete your evaluations and claim your credits. Now, without further ado, I'd like to go ahead and begin today's program by introducing our panel. And so I'd like to start with Jennifer Milton, who will first take us into the first section of this program. Jennifer Milton is a clinical assistant professor and the chief administrative officer at the University Transplant Center, where she is charged to integrate the business, operational, quality, and strategic efforts for University of Texas Health San Antonio and the University Health System. We are also joined today by Helen Irving, who was appointed president and CEO of Live On New York in 2011. The former critical care nurse brings more than 30 years of clinical and business expertise to the transplantation field, including her role as VP of Hospital Operations at Mount Sinai Medical Center. She established the Live On New York Foundation and played a key role in launching New York's first face transplant program with NYU Medical Center. Lastly, we'll be joined by Brigitte Sullivan, who is a transplant program consultant after having worked as a transplant administrator for over 25 years at both Johns Hopkins Hospital and NYU Langone Health. Brigitte has been involved in both transplant center and organ procurement organization operations and financial performance, as well as in national policy development. We are so honored to be joined by all three ladies today. And with that, I'll go ahead and turn it over to Jennifer to begin today's discussion. Thank you.
Warm introduction, Deanna. I can't move on without telling you that our entire community owes a tremendous gratitude to the board and staff of the Alliance. As you can see, the mantra of the Alliance, advancing organ donation through leadership and engaged learning, has certainly come to bear. Given the urgency to raise awareness in our community of the existence and the potential impact of this proposed rule, the Alliance found a date quickly for us and allowed it to be open access so non-members could register. Nearly 700 of you have, with 80 questions submitted in advance. Clearly, our community is concerned. Emails to our state hospital associations and the American Hospital Association even extended in invitations to those groups, and we welcome you here today as well. Another incredible thank you to my colleagues, Brigitte, for some furious work and analysis that she'll share momentarily, and Helen for really opening our eyes to not only the short but potential long-term impact for OPOs and the transplant community to consider. I do refer to this rule as this proposed rule as the most substantial change in organ donation and transplantation in my 27 years in both fields. And our plan is to give you a high-level review of the components of the transplant and organ acquisition sections of the proposed rule. I'll turn it over to Helen, who's going to talk about some potential impacts for the OPO donor hospital community and others, and then Brigitte to share with you the analysis on the impact to transplant centers, availability of organs for transplant, touching on children's hospitals as well. And then I will wrap up with sharing directly, if you are concerned about the impact, how to activate on that and submit a comment to the proposed rule. And as you can see here, we've listed you as the fourth speaker. The reason you're listed as the fourth speaker is that the Alliance and my colleagues have graciously agreed to stay on beyond our allotted time for an extended Q&A. Every time Brigitte, Helen, and I have discussed this proposed rule with colleagues, our professional organizations, we all commented on how we've learned more, that there's so many nuances to the rule, hearing from others and sharing concerns, ideas, and even just going through QA has resulted in us digging a little deeper. So with that long introduction, I'll move along. There we go. So I thought I would begin by just a little education. These changes were published as part of the FY22 Inpatient Prospective Payment System proposed rule. For my OPO colleagues, you may not be as familiar with the IPPS, and really it is because it's designed and centered around largely acute care hospitals and how they're reimbursed. It provides bundled payments for Medicare Part A centered around what we call diagnostic related groups, DRGs. If you work in the OPO world and you've not billed private insurances or billed Medicare directly for delivery of patient care, that may not be familiar to you. In short, it was really designed to control costs, so Medicare could, you couldn't bill Medicare for an unlimited number of tests and procedures. You really got a capitated reimbursement. And in general, when Medicare issues changes to the proposed, to the IPPS or any major proposed rule, Medicare in general is required to provide a detailed impact analysis. The section that we're covering today is just part of the IPPS proposed rule. But if you read the whole IPPS carefully, you will not see a detailed impact analysis to the donation or transplant community. And we hope that you'll reflect on that as you submit your own public comments, which we'll touch on at the end of this presentation. I want to share with you that overall, the FY22 IPPS proposed rules have been very well received. Even on the American Hospital Association's public website, after a preview on April 27th, they used the terms very pleased, heartened, pleased, encouraged to touch on multiple components of the rule. The Healthcare Finance Organization and the Healthcare Financial Management Association also shared highlights, really noting, applauding the improved reimbursement to acute care hospitals, extensions related to COVID-19 treatments, funding, residency programs, etc. But what we found in all of those late April, early May summaries that were reaching many of our hospital executives is that the summaries and the news outlets excluded any mention of the transplant and donation community and the impacted sections of that, which is what we're going to cover for you today. I hope I didn't get click happy there, advance too much. There we go. On May the 3rd, I got this daunting email. It was from my colleague, Austin Williams and Mike Rossi at Penn Transplant Institute. They had really been deeply reviewing the IPPS proposed changes. And as you can see from this email from Austin, hey, Jennifer, have you seen this proposed rule? In fact, the Texas Hospital Association had already reached out to my executive leadership, commenting favorably on the overall IPPS rule. And this really began an in-depth review of all of the changes. So big thank you to Penn Transplant Institute. And since this email, a group of about 30 transplant centers or government relations and cost report specialists have been meeting on Tuesdays to sort of organize our review of the impact of the potential proposed rule. So I'm not going to go over these slides in depth. They're largely for your enduring material. As Deanna shared earlier, these slides will be posted on the Alliance for your to access later. But in short, the proposal is to codify long-standing 34 years, in fact, Medicare organ acquisition payment policies, clarify and some terms, and set for some new payment policies. This goes, the public comment period ends on June the 28th. That's the last time you can get your voice heard on this, and it will be effective, this change, on October 21st of 2021, a remarkably short period of time. It lays out a historical review of the intent behind the organ acquisition payment policies. And it does go on page 1506, highlights 12 items as cost of acquiring kidneys and applying to all organs. Brigitte, Helen, and I will later touch on the impact in these key areas, but I largely want to cover these sections for you as a high-level overview today. The organ acquisition policies and what is not counted by OPOs as organ acquisition is covered on page 1510. Helen is going to cover the potential impact of that section momentarily. Medicare does go on and reiterate or re-educate the transplant community as to their charge to our community of billing and developing both a standard acquisition charge for living donation and cadaveric donation. But I have been pointing out that although our transplant centers had developed these internal SAC charges to bill for living donation or account for all cost of billing for living donation or cadaveric donation, in general, most commercial transplants are paid for by about 5 or 6 large insurance companies. Their common contractual strategies actually require transplant centers to only bill, or they'll only pay for the organ at the actual invoice from the OPO. So although Medicare does re-educate us that we are supposed to develop these SAC charges as a transplant center and pass them on to private insurers, that's not typically the strategy involved. Further, we really work into contracts with large global rates, our global rates, and the global rates really don't cover that infrastructure and overhead that Medicare explains to us we should calculate there. And often even the Affordable Care Act health insurance plans reinsure through these commercial payers. It does go on to further point out to OPOs how to bill for their standard acquisition charges. Helen is going to touch on some of that momentarily, and touches on HLA labs and other laboratories fees. The accounting for costs or services provided to living donors is a component of the proposed rule many transplant centers have commented on in the transplant center and quality listservs. And I will just point out here that this does afford our community a great opportunity in our public comments to address the Medicare Advantage plans that treat living donation and coverage as really commercial, defaults to their commercial coverage rather than Medicare coverage. And it might be a good opportunity to publicly comment on that. And that, and later I'll touch on the restriction of registration fees to only the OPTN fee. Another good opportunity for public comment here is it is in this section that starts on page 1518, where Medicare offers further clarity that they do not cover routine follow-up, the OPTN mandated periods of follow-up. And if any of you attended ATC's living donation roundtables, rapid abstract fires, you know that experts in the field certainly call not only for 2 years of donor follow-up, but actually very long-term follow-up of donors. But again, this proposed rule specifies that that isn't excluded, that those are only for collecting data and not for the health or for the medical needs of the donor. So I hope that you'll consider a public comment there as well. Helen is going to largely touch on some of the differences between Medicare's differences in how you bill pancreata that's used for islet cell research versus for implantation or transplantation. But the most critical part of the bill really falls to this next section, which is how Medicare is going to move forward and allow transplant centers to count Medicare, their total Medicare organs. So, and this is just a direct quote from Medicare. They do not share in the cost of acquiring organs that are not transplanted into Medicare beneficiaries. And organs that are not transplanted into Medicare beneficiaries will not be used in the denominator of the fraction of Medicare usable organs. You may recognize that language specifically from the email that Austin Williams sent to me. Austin, Penn Transplant Institute, my own transplant institute, Brigitte's, others in the country have been collaborating on assisting our OPOs with hospital-based organ recovery centers. So this is why he brought it to our attention. Two components in this I've highlighted in red here, and I just wanted to stress to you is that, and certainly may be fodder for a public comment. In the first circle in red, Medicare notes in the proposed rule that a significant number of kidneys are being shipped overseas, and that was certainly cause for their concern in publishing this proposed rule. And we can touch on that later during the Q&A session, but not information that our community seems to be able to verify. Also, Medicare really alleges here to the ease of determining if the ultimate recipient is truly a recipient who has received as a Medicare primary payer of the beneficiary, and the administrative burden of that task. Helen's going to touch on, and we'll touch on later as well, that certainly has been widely circulated in the in our listservs. That is a pretty impossible task, in fact. I've touched on the, and so two other components I'll cover before I turn it over to Helen is that in a separate section of the proposed rule, Medicare directs the physical intermediaries that two things will be required to determine if an organ has a Medicare secondary liability. Since we'll only be able to count those organs and if their ultimate recipient has select forms of Medicare, these are particularly important. First is that Medicare calls that in order to determine it's a Medicare secondary liability, it will be necessary to review the transplant hospital's agreement with the primary insurer. And secondarily, they will have to verify that a bill was submitted to Medicare and there was a liability there. So in short, to determine if the ultimate recipient has an organ, the same two requirements would apply. And in fact, there are some concerns that have been raised that may not even be legal for one transplant hospital to share with an OPO or even a transplant center determining if that will be to review those contracts. I've covered the acquisition charges for kidney paired exchanges. That's on page 1541. We certainly recommend calling for public comments here with the Advancing American Kidney Health goal of doubling the number of kidneys available by 2030, that not supporting the kidney paired exchange, the UNOS registration fees, et cetera, that actually could be a further disincentive, or maybe we're missing the opportunity of it being an incentive to increase organ donation. And then the final last call in this is to call for information from our community on surgeon fees for cadaveric donor excisions, but everything else will be codified as a change on October 21st. And Helen is going to touch on this part that I've circled here, which is one of the final provisions in the rule related to transplant centers on page 1548, which is related to the portion I circled there, that stakeholders have alerted CMS some donor hospitals are charging OPOs amounts that are in excess of reasonable cost. So here I'll turn it over to Helen. I apologize for my brevity, wanted to give you a high level overview of multiple components of the proposed rule.
Oops, and I did exactly what I wasn't going to do when we practiced. So thank you, Jennifer. My name is Helen Irving. I'm the CEO for Live On New York. And by no means am I a CFO or a financial expert. So this really is a high-level review of what we've been finding and what our interpretation is on the new regulations. And as Jennifer said, the more we talk to each other, the more we are looking into what does this mean? And I sometimes feel like I'm playing the What If Olympics. So the one thing that struck me very immediately was that there is a preamble there that acknowledges that the payment policies are not consistent with the performance metrics for OPOs. So CMS really is saying that we know you have to do X, Y, and Z, but we're actually not going to pay you for that. You'll be paid for A, B, C. And so there's immediately misalignment with what we actually do day to day. And, you know, the definitions for independent OPOs, transplant hospitals, hospital-based OPOs, and HLA labs, I'm not going to go into that, but there is really clarity around how we are defined. And that's really important because it does lead into how we are looked at in terms of our budget and how we set our fees. Hospital-based OPOs set their fees based on the transplant hospital's previous year's cost report versus an independent OPO that really looks forward. So one is based retro, one is looking forward. This is not unexpected, and I'm actually surprised that they didn't move OPOs into a DRG reimbursement process, but that's yet to be seen. I do think it's important, Jennifer touched that this is coming up in October, but if you are a hospital-based OPO, of which there are 7, yours will be retro to January 1 of this year. So just know that you will have to go back and realign what you have been billing in accordance with these new regulations. And my colleagues at Greater New York pointed out to me that this proposed rule is actually coming out of the hospital side of Medicare. But please know that there is another proposed rule which will deal with physician Part B payments, and that is due to be published in July. So for those of you on the transplant center side, I would keep an eye out for that document as well, just in case there are any other changes regarding physician payments. And so we touched a little bit on, the en bloc, the pancreas and discards and invoicing of SACs between OPOs. The biggest part here, en bloc is fairly logical to me. It's, if 2 organs go in one patient, it's counted as one. But the pancreas is a little confusing because the pancreatada is only going to be billable here if, in fact, it goes islet cells. The pancreas is going into a Medicare beneficiary who is enrolled in a study with the National Institute of Diabetes. So OPOs right then and there are going to have to figure out how we're going to track all of this information. And we'll talk a little bit about discards a little bit later. What I tried to take out of this was just the high level big changes that I could see for all of us, but I wanted to start a little bit with a financial coordination lesson for the OPOs of what is a Medicare beneficiary, because I know those of you that are in the transplant center world do this every day. And when we saw that OPOs could only bill for organs that went into Medicare beneficiaries, it didn't, at first blush, it may sound quite reasonable, but we actually don't have any access to the insurance information. And that would require that the OPTN allow us to see that because it is submitted by the transplant center. But however, it's submitted on when a patient is listed and isn't always up to date. And you know full well, a kidney transplant recipient can be listed in year 1, but not transplanted till year 8. And there could be many changes in insurances across that continuum of care. So it's not current, and we would actually be in a position where we would have to be calling our transplant centers for confirmation of that beneficiary. And also, I'm assuming we're going to have to provide the Medicare beneficiary's number as well. And so whilst it may seem on the surface that if you're dealing with a Medicare primary payer, that may sound quite reasonable. However, Medicare has a lot of secondary liability that Jennifer touched on. And quite often Medicare can be primary and can have a secondary insurance. But when you're first eligible for Medicare and you have a commercial insurance, the commercial insurance remains primary for a coordinations of benefits period. And then after 18 months, Medicare becomes primary. So in a coordination of benefits scenario, it may appear that a patient could have Medicare, but Medicare is in fact secondary and becomes primary after 18 months, which leads back into the OPN data not often being accurate for insurance verification. And it really is not. From what I recall from my clinical days, it really asks you Medicare, Medicaid, commercial, and that's about it, right? Nothing else. You've also got the issue of Medicare Advantage plans. So these are plans that on the surface appear as if they're a commercial payer, but they're actually Medicare. And these are all these plans that you can purchase your Medicare, use your Medicare dollars through United, through Oxford Health here in New York. Those are actually Advantage plans. So that's very, very different. As someone's just corrected me for the coordination of benefits period, I'll leave that to you guys, whether it's 18 months or 30. We can answer that at the end. Global contract implications for OPOs. OPOs have not had to deal with global contracts at all. And so it's really going to be difficult to figure out if there is a secondary liability, if in fact the transplant hospital contract for that particular transplant is paid in full, or if in fact there is a liability for Medicare, and then what does the OPO do with that? So we're somewhat going down a pathway of dual billing. We're going to be billing Medicare beneficiaries and having to pull out all of those others. And does it really mean that we now have to have a new career pathway in the OPOs, in that we will need, similar to the transplant centers, we're almost going to need a financial coordinator to really run through all of this for the OPO. And depending upon the size of your OPO, that's going to lead to some increased costs. Certainly in the New York area, a financial coordinator at $65,000 to $75,000, $80,000 a year salary plus 30% benefits, you multiply that out by 57 OPOs, and then you can see how those costs could increase. So again, this is more for the benefit of the OPO folks. I know on the transplant center side, you live and breathe this every day. So where do we start with our disincentives? And the biggest one I see is really for the donor hospitals. So here, everything that the donor hospital will be billing the OPO moving forward after October is going to be based on the cost to charge ratio. And the way you think about that for a cost to charge ratio is that there are usual and customary charges that are billed out for a service. There's a fee for service as well. There's general charges for private payers. But cost to charge really says, how much does it really cost us to produce that chest x-ray? And maybe it's, I'm making up, maybe it's $3 for every chest x-ray, all right? Because there's economies of scale. That's what cost to charge does. It reduces everything down to the lowest denominator. So for an OPO, what it will eliminate for us is if our contracts are our memorandums of agreements with our OPOs of fee for service, or if they're global contracts, we do have global contracts on our side as well. And we do have some that are reasonable and customary charges, but it's really going to eliminate all of that. So that's going to be a big change. And it also, the cost to charge is based on what you put on your hospital cost report as well. So really, there's no incentive here. It's basic charges. And the other part that's really unclear is if the OPO is required to pay these bills, or is in fact the donor hospital going to be impacted by this Medicare beneficiary? So does in fact the donor hospital get paid if in fact the organ goes in a Medicare beneficiary? That's kind of stretching it a little bit, but I do think that if the OPO could be at risk for not being paid, if we end up discarding and having a zero organ donor, we still have to pay that donor hospital as well. So again, increasing competition for our ICU beds, we always hear that in the field, that we currently are told, we're not paying enough for the services that are needed for a donor. I think this is actually going to make things a little bit worse for us for a while. And for those in the hospital development world, we know that we do a lot of CEU professional education programs. That's not covered. And for our donor hospitals and for organ donation in general, we rely on a lot of third-party services. We have couriers, we have people that read our biopsies, we have people that read our echoes. There's all sorts of systems that we have invested in, and there could well be an impact on all of those third-party contracts in terms of what we can be reimbursed for. So the discard issue is the biggest issue. We know that discards have gone away from the clinical performance measures, but there's really confusion around this. And this is taken right from the final rule. The last 10 pages are where the rule is written. And really what it says is an organ is not counted as a Medicare usable organ or a total usable organ if the excising surgeon determines upon initial inspection or removal of the organ that the organ is not viable and not medically suitable for transplant. And if it's determined to be unsuitable and discarded. So right here is where that Medicare usable organ comes right out. And it's also saying that counting for research organs for Medicare cost allocation purposes, organs used for research are not counted as Medicare usable organs, except for the pancreas, in accordance with the previous rule. So here is where, what are we going to do as OPOs if we're pursuing marginal organ donors? Where does this marginal case fit in? And kidney allocation quite often occurs after the recovery has taken place, particularly in rapid recovery cases where, families really would like us to go to the OR within 4 hours and we really need to move and move fast. Is the OPO now at financial risk? And with all of this, where will we be sitting with advancing organ preservation, with ex vivo technology that really may take a discarded organ, but in actuality, we can actually make it a little better, we hope, and then look toward placing that organ later. So there is some confusion and unclear right now as to where we go with this. The other place where I'd like to focus is on the organ recovery centers. You know, data has shown that when we've built these centers, in some circumstances, our organs transplanted per donor has increased, and we've seen success. And that's why there are many OPOs across the country pursuing recovery centers, either as independent recovery centers or as a joint venture. We also have residents that come out to recover at times. So you have to make sure your resident is in a non-GME program, a non-Medicare funded program. However, hospitals also have caps on how many residents they can have, but they can also increase that cap by agreeing to pay a salary for an additional resident. So you may not know how that resident is being salaried behind the scenes when they're recovering for you. And I really think we're going to have to reassess the return on investment for recovery centers. And this is the main reason why transportation of the donor is not covered. So if you have a recovery center where you are flying in your donors, where you are transporting by road to the recovery center, the cost incurred of that transportation is not covered in this scenario. And also, if we transfer a donor, we certainly do this in some of our community hospitals in my service area where we don't have overnight cardiac cath labs and we're transferring to another hospital for that service, that whether the transportation of the donor for that purpose appears to not be covered. And we may also be transferring donors to other hospitals for the purpose of DCD recovery if you're in an institution that either doesn't have a policy for DCD or has an objection to that process. And so that's another area. And overall, you know, if some of our independent recovery centers are unable to fly their donors in, there's going to be an increase in cost if they stay at their current site and all the teams now have to fly out to that donor hospital. So now you've got 5 flights instead of just 1. And where the transplant hospital acts as an organ recovery unit, so they have recovered organs on the transplant hospital cost report. They also have proposed organs sold, which would be at the transplant hospital SAC and cost as well. But are they subject to the same issue as the OPO in terms of a Medicare beneficiary? And can that organ only be placed on their cost report when it is transplanted into a Medicare beneficiary, or does it move forward as a sold organ? So with that, where I'd like to leave this, and again, as we said earlier, this is really very high level. I know Brigitte's going to follow me with some of the money and follow some of the finances for this, but I do think there's a significant issue with incentives for donation for our donor hospitals, for our recovery centers that have had proven success. For transportation of our donors, we are going to see innovation. Where does that fit into all of this in terms of moving our agendas forward to increase the use of a marginal organ? There is a question around financial stability for OPOs if you're required to pay donor hospitals, but you're not then going to be paid yourself. And third-party services, may that also end up being down to basic cost, and will they be willing to continue to provide that service for us at cost when there's no ability for them to make any profit? And the return on investment for organ recovery centers will need to be reevaluated in this new payment structure. And so with that, I'd like to pass over to Brigitte, who will be able to give you an update on some of the financial analysis she's put together from looking at all of our cost reports.
Thank you, Helen. Let's see if I have control here. Okay, thank you. So as Jennifer mentioned, we've been having Tuesday morning meetings with some other transplant hospital administrators and conferring with OPO leaders and others. And we really wanted to try to get our arms around what type of an impact that these rule changes would have on our hospitals. So using the Medicare Cost Report data, which for hospitals is available on CMS's website, it's a public website, and on the slides you'll see the address for it. I downloaded all of the cost reports that were submitted in fiscal year 2019. And for this analysis, I really was only able to focus on the changes related to deceased donor reimbursement because it's impossible to tease out the living donor components from how this data is reported on the cost report. So the big changes with the proposed rule are, one, as Jennifer and Helen have both been talking about, it changes the way that we're allowed to report donor organs procured at our hospitals as Medicare usable organs. Only those that get transplanted into a Medicare recipient ultimately can be counted. And it excludes the costs of transportation of deceased donors, which historically hasn't been excluded. So first, I'd like to go over just some of the basic mechanics of the cost report. What you see here is the third page of the D4 worksheet of a transplant program's cost report. And any hospital that has a CMS certified transplant program for a specific organ is permitted to report their costs on these D4 worksheets. So this is an example for a heart transplant program. And if we go down here to these yellow lines, lines 76 through 78, this is where the transplant hospital reports those donor organs that are sold to either other hospitals, OPOs, or other transplant hospitals. Mostly these, we are with hearts selling those donor hearts to the OPO. So these lines together add up to the organs excised in the provider, or line 70. Also down here reporting the organs purchased from OPOs, and those would be organs that we purchase, hearts that are then transplanted at our center into transplant recipients. And that's down here 2 and 75, row 75. So up here on the cost report, line 61 is the total costs that have historically been allowably reported on the cost report for both recipients and donors. And then the total usable organs, this 59, the instructions on the cost report are to take line 74 and minus out line 83. So line 74 is this total of excised in the provider plus purchased from the OPO or transplanted, and minusing out, I'm sorry, we can't see this on the screen, but down here is a unusable or discarded organ as one. So one of those hearts was discarded. So the total usable organs are the 60 minus the one discarded, or 59. Now, Medicare usable organs historically and currently are the portion of these 50 transplanted organs that went to Medicare recipients. So for your patients that you transplant at your hospital, those that went to a Medicare recipient, plus all of the organs excised in the provider minus those that discarded. So in this situation, we say that the transplant patients, 30% of them were Medicare. That would be 15 Medicare recipients, plus the 9 organs excised minus unusable or discarded organs. And actually, I'm on the wrong slide here. I'm so sorry. It's 24. So the 15 Medicare primary plus the 9 excised in the provider. Our Medicare share is 41%. Then this Medicare cost to charge ratio is going to be 41% of the $4 million of total costs. We then minus out revenue that the OPO pays us for those donors, and that can be a contracted rate, that could be cost, et cetera. In this case, for these 10 donors that we sold, we got $50,000, we minus it out. And so Medicare reimbursement now is $1.577 million. Okay, that's the amount Medicare reimbursed this heart transplant program in FY19. Now let's look at what this would look like, under the new rules. So we still have the same $4 million of cost. We still have the same 59 total usable organs, but now this Medicare usable organs goes down to only 18. So it's that same 15 of the 50, and that's 30%. And then if we assume that the 9, the 10 minus 1 discarded, that if we assume that those 9 recovered at our hospital, only 30% of them went to Medicare recipients, just like the transplants, then that gives us 3. So 15 plus 3, and it changes our Medicare ratio to 30%. So now the Medicare cost to charge is $1.2 million. We minus out the revenue just for those 3 donor hearts that we got from the OPO. And our new amount that we get reimbursed from Medicare is $1.185 million, or it's about $400,000 less than the previous example when we had the 41% share. Now with the 30% share, we are getting $400,000 less back. So if we look at all of the cost reports that were filed in FY19, we can see the overall impact using the same methodology. So here for all the heart transplant programs that filed cost reports in FY19, $530.7 million of costs, 4,637 usable reported organs, 1,915 Medicare usable organs, or a share of 41%. So then the Medicare cost to charge minus the revenue. So 184.5 million reimbursed to transplant hospitals for heart. And then if we do the scenario again, where we say only a portion of those donor organs that were recovered at the hospital went to Medicare recipients, it reduces our Medicare usable organs from 1,915 to only 997. It reduces our Medicare share from 41% to 22%. We minus out the revenue sold. And now our new Medicare reimbursement to hospitals for heart transplant goes down $74 million. And if you look at all the organs combined, it's $383 million. This is very different than the $230 million that Medicare estimates in the IPPS language as being a reduction. On average, and you'll be able to see in the materials that the Alliance emails out, as well as it's available on their website after our talk, you'll be able to see your specific hospital and organ program detailed out in this Excel file. But on average, there was a reimbursement decrease of $1.7 million per hospital. The other thing is the new proposed language does not discuss or change how the organs sold, the revenue from the organs sold, is offsetting what's reimbursed by Medicare. If that language isn't changed and the entire amount is to be offset, it's an additional $84 million reduction of Medicare reimbursement based on that FY19 data, or $1.9 million per hospital. Really upsetting is that children's hospitals are disproportionately affected by this. They account for 4% of donor organs and 6% of decreased revenue. And this is because they have a very low percentage of Medicare recipients because they're young children, and also a similar low percentage of recipients of pediatric organs from those donor organs that they're recovering at their hospital. So this is a particular concern. The model that we looked at too certainly doesn't take into consideration the delays in Medicare coverage that have been described by my colleagues, but also, when we have a patient who has ESRD and is able to become effective for Medicare the date they got transplanted, if they haven't started dialysis yet, that can take several months. There's lags in there. How do you go back and figure out if that kidney that you recovered at your hospital went to a Medicare recipient months and months later? And then the other big impact financially is some states, and Alabama is one that I've had some conversations with, use Medicare data to calculate the payment rates for Medicaid patients and utilize the Medicare Cost Report and the total reimbursements to affect how much federal dollars they get for Medicaid reimbursement as well. So this has other far-reaching effects outside of just Medicare. Helen did a great job of talking about how this new rule may disincentivize donation. And so through our discussions with other colleagues, we've tried to come up with some modeling to look at what that might look like. And I think the big picture of all of this is that we really want to urge CMS before any type of dramatic change has been proposed, is put forth that a thorough impact analysis be done so that we can really have a better understanding and they can have a better understanding. And since it hasn't been done, here are some of the factors that we looked at. So that financial disincentive to pursue marginal cases, when Helen described an OPO still must pay the donor hospital when there are no organs that are ultimately transplanted, but they don't have a mechanism for recovering those costs of those donors. Hospitals that don't have DCD protocols for religious or other reasons, or hospitals that lack certain testing for donors and therefore the donors are transported to another hospital for such testing or transported to facilitate DCD donation. In some geographic areas, this is as high as 20% of DCDs from non-transplant hospitals where it's occurring. Helen talked a lot about transplant centers that have partnered with OPOs to facilitate central donor recovery services in their hospitals. And when we collected data from those central donor hospitals, their organs transplanted per donor rates ranged between 13% and 20% higher than the donation services area rate was prior to implementation. It's pretty significant. And then as well, factoring in competition for resources of commercially insured living patients with potential donor patient payments, if they're just being donor hospitals are being paid at cost. They may not be as able to continue to keep patients in the ICU while they're being stabilized to maximize use of lungs and other organs that usually needs some time and stabilization. And then of course the pressure of when the operating room can be used and when organs are allocated and ensuring there's enough time to be able to utilize the organs. So let's see what that looks like. This scenario is just looking at kidneys, really because the executive order for kidneys is so potent and really outlines exactly how CMS and HRSA want to see kidney transplantation expanded. So I modeled out conservative, moderate, and then significant scenarios. First, looking at those older donors, so donors more than 65 and thinking that they would not be as actively pursued by OPOs for fear of discards and not being able to recoup costs. In calendar year 2020, there were 819 of them. They produced 453 kidneys. If we saw a decrease of 10% of those 819 donors, it would have meant 45 less kidneys recovered and transplanted. The moderate scenario uses 20%, that it would have resulted in 91 less kidneys, and the significant uses 30%, resulting in 136 less kidneys. Next category is DCD donors that are less than 65, but at non-transplant hospitals. And if there's a decrease in being able to transfer those donors or be able to conduct testing on those donors, just looking at those at non-transplant hospitals, there were 1,993. They produced 2,970 kidneys, and just a 5% change or decrease in that would be 149 kidneys, ranging up to almost 600 kidneys in a significant scenario. And then lastly, brain dead donors that are less than 65. If the organs transplanted per donor rate decreases due to some of these hospital reimbursement disincentives and diminished number of donor hospitals and centralized ORs, if that organs transplanted per donor rate diminished by 5%, it resulted in a loss of 675 kidneys, ranging up to 2,000 and almost 700 kidneys on a significant scenario. So factoring in these not unrealistic disincentives, in the conservative, we get to a loss of 869 in a year, moderate 1,737, and significant 3,428. And below here, if we just look at the healthcare costs of this for kidney transplant, the US median waiting time right now is 3.53 years. Looking at the USRDS published costs for Medicare for dialysis versus transplant patients. And when we extrapolate this all out over 3.5 3 years. It's on the conservative side, about $85 million a year of additional costs keeping patients on dialysis versus transplantation, all the way up to 337 million for the significant scenario. So again, in addition to the better quality of life that you have with a kidney transplant, there's also a significant cost associated with not being transplanted. This is what those scenarios look like for the other organs. You can see livers on the conservative side, 436 less a year, up to 1,700 and so on and so forth. And if you think about it this way, the significant looks really significant with almost 7,000 organs, deceased donor organs, less in a year. But this would actually, if we had that volume, put us back to the volume that we had nationally of deceased donor transplants in 2016 numbers, 2016. So it's not completely ludicrous to think that this type of deterioration could happen. The model, of course, also doesn't factor in transplant centers making choices about using some of the innovative approaches that have been advanced over the past few years, that have been possible because we've had some more freedom in what costs can be reported, as well as being able to report deceased donor organs that have not necessarily gone to a Medicare recipient. So I'm going to turn it back now to Jennifer to talk about how all of us can be involved in hopefully affecting this rule.
Thanks, Brigitte. Every time I see those numbers, it scares me more. And I really am just showing you a slide of one of the favorite presentations I gave at Transplant Quality Institute called Rock the Vote. And it was really to outline for individuals how they could get involved with public policy. And so let me tell you what we need, what you can do. We tried to give you an overview, an area of potential impact. I'm going to skip that so we can get to the QA. But here's just 14 quick things that we're concerned, other transplant centers are concerned about the impact. Will it decrease deceased kidney donation? Will it impact the average wait time? Will it impact the known disparities our community has in our multicultural populations? What are the systems barriers needed for OPOs or transplant centers to confirm primary and secondary payers? We would like, substantiation of statements that deceased, substantial numbers of deceased kidneys are shipped overseas. How about the impact on transplant centers up to and including closures, particularly children's hospitals that perform transplants whose Medicare counts are impact their Medicaid reimbursements, and it goes on and on. So what can you do? And you're doing something could not be more critical. This screenshot is from today. First thing I've underlined is that this document comment period ends in 14 days. The link to get on here is attached. It will be put in the documents afterwards, and there's just a button that you click to submit a formal comment. We met with the executive vice chancellor of the UT systems, and what he cautioned us to know is that for Medicare proposals, it's often how high the stack of letters are. It's not just how well written they are or the power behind the organizations that write them. So I use my Rock the Vote slide to say to you that it is you, individuals, over 700 people registered for this. That could be 700, 800 letters making our stack very high. And your letter doesn't have to be in-depth informed. It could simply say, we're calling for a delay in the implementation of the transplant and organ donation provisions of the proposed rule and a study to analyze the impact prior to implementation. I will end it there and turn it over to our Q&A. And again, we're going to stay on for anyone who's able to and may have Q&A. I think we answered about 15 questions, but we're happy to stay on until all of your questions are answered.
Thank you, Jennifer. I would just like to reiterate as we transition to our Q&A discussion. For those of you that are sticking with us and have questions for our panel presenters, please feel free to submit them. Just as a reminder, you're going to go ahead and submit them using our Q&A box, and we'll be sure to address them in the order that they're received and try to get to as many of them as we can. So with that, I'll turn it over to you, ladies. It looks like we do have a few questions in the queue already.
So I think, hi, it's Helen. I think just to answer, Howard brought up a good point about the overseas organs. You know, the chances are that's more than likely referring to Canada. I couldn't think where else we would be sending them. But very few, and I was actually surprised when I saw that was in there. But not surprised that they wouldn't reimburse if organs went to Canada.
Looks like we have a question from Erin Davis. What is the most likely outcome with all of these responses? Will CMS pause on initiating this proposed IPPS?
Well, this is Jennifer, and no, when I look through, you saw my slide showing that there have been approximately 90 public comments so far. When I click on those public comments, they are largely in support of the IPPS rule overall. Again, I mentioned at the beginning, this is viewed quite favorably. Transplant reimbursement, donation reimbursement affects a small number of us. As Brigitte showed, that small number of us expect a $383 million loss. And it's completely up to those of you watching this in our community to write those letters and call for a delay. Pointing out that there's some concerns or areas where impact hasn't been addressed is simply not going to be enough. Writing a letter is the only thing that counts.
So there's also a question here from Leonard as well. And Leonard, I actually had the same thoughts as you as to whether the OPOs would charge different rates for Medicare beneficiaries versus non-Medicare commercial payers. And that's unclear, but it certainly says you can't do it. But I wondered that as well myself. And again, this would be very similar to how hospitals are paid for their services as well.
And this is Brigitte. I see Denise Paquette asked about the impact analysis, and I actually did the impact analysis, not the Alliance, but the Alliance will be posting and emailing out the Excel file that has each individual hospital and organ programs D4 data modeled the way that I just showed. So you will be able to see it for your particular hospital.
Thanks, Brigitte. We do also have a question here from Alexandra. Do you have any suggestions for simple language that transplant programs can send to referring providers so they can engage in this discussion with CMS? All hospitals are affected when transplantation goes down.
I sure love that comment, and I couldn't agree more. We are going to post a sample letter, and I circulated on the Transplant Administrators listserv. It's really hard to post simple language when it's such a big thing and so many different elements. So, but we'll post the sample letters and a sample impact statement for your use to distill down and communicate.
Thank you, Jennifer. I do also have a question here from Valerie. What would be the best change in language we could advocate for in addition to a delay?
As I've stated, I think that would be a delay to study the impact, or a delay and an analysis of the impact. Since the impact really wasn't analyzed and provided as part of the published document, I think it was really left to our community, like Helen and Brigitte, and the others of us that are meeting, determine what that impact would be. Certainly having the weight of HRSA and CMS to do such an analysis would be extremely helpful. Medicare has clearly made strong claims here that are important, that commercial payers should be paying a broader share. I think one of the comments from Gigi Spicer earlier was even that commercial payers should share in this. One of the professional organizations that is working on a public comment even shared that may even require legislative action. to get commercial payers to pay a broader share, or truly what the SAC fees are being called for here: infrastructure or quality, organs that are tested and then not transplanted. Those costs we really haven't been able successfully on a large scale to pass on to commercial payers.
Jennifer, I do have a question here for Brigitte. How did you come up with the Medicare organ percentage in your D4 analysis?
I used what each hospital had reported as their percentage of Medicare transplant recipients on the cost report. So not talking about the organs that are recovered there, but just for the patients that they transplanted, how many were reported as Medicare, and then applied that same percentage to the donor organs, thinking it would be a similar percentage.
Thanks, Brigitte. Looks like we have a comment / question here from Chris Wood. Given that evaluation costs are a part of the organ acquisition costs, and Medicare does not pay fee for service for these evals, and not every patient is actually listed or transplanted, how are transplant centers supposed to make up this difference between costs incurred for all Medicare patient evaluations versus what is paid by the Medicare Cost Report? The counting of all recovered organs seems to have helped offset the cost of evaluations for patients that do not make it into the ratio by being transplanted.
Yeah, I mean, that is correct. It's, but I think if you're just looking at the recipient costs and you're reporting all of your recipients, not just your Medicare recipients as your total cost, then, theoretically, the recipients that you transplant, you're getting that share back of there. But, you're right, it will be less because it was further enhanced by rewarding you for doing a good job at recovering organs and facilitating donation.
And I did want to just comment that just to make sure this point was really stressed for those of you still listening, is that because of the 21st Century Cures Act, as of January 2021, recipients of kidneys with Medicare Advantage are considered part of organ acquisition or the Medicare count. But if you focused in on Brigitte's analysis showing the impact for extra-renal organs, liver, lungs, hearts, intestine, et cetera, the Medicare Advantage patients aren't counted in that Medicare ratio. Another burden if OPOs are expected to track if the ultimate payer was Medicare, because they're not used to billing those payers. But in my own transplant center, my Medicare ratio for liver is going to go to 9%. And effectively eliminate my perfusion program because those technologies haven't been FDA approved or adopted widely by commercial payers until such time contracts can be renegotiated. So I think the conservative mid and estimates Brigitte shared I really think about the impact on normothermic and advanced innovative technologies for those extra renal programs.
Thanks, Jennifer. I have a question here from Paul. Historically, the HHS secretary has acted to modify or postpone proposed rules. How is the industry attempting to influence the administration?
I can share a little bit of some of the approach that's being worked on. First and foremost, if we don't have individual letter writing, I think we can kind of forget intervention. So we have to have a broad and diverse set of opinions coming in on this. So it's clear it impacts the impact is worrisome. Secondly, there is an attempt to reach out through government relations office to individual congressmen to try to get a congressional letter written to HRSA inquiring specifically about these areas of impact. You may remember from some of the congressional hearings on OPOs and other things that have come of late, including broader sharing, letters that were written by congressmen directly to HRSA. HRSA needed to stop and take the time to make that reply. So Lots of that work is being done. Don't hesitate to reach out to your congressman through your own governmental relations department. But, certainly worrisome. It's July 14th. Public comment ends on the 28th. We don't have a dramatically organized group of individuals, although we're very thankful ASTS has published their call to action last week.
And another step that you can take is actually partner with your hospital association if you've not done so. So I know we're working very closely with Greater New York Hospital Association because they do represent all of our transplant programs. Actually, they represent all of them in the state of New York. So we're working with them for a response as well.
Perfect. Thank you, ladies. I'm looking to see if we have any additional questions in here. It looks like we have a few comments, a few requests for resources and language. So just to reiterate, we will be sure to share all of that with you all via email, as well as through our community resource toolbox. All of the sample language and letter samples will be uploaded there. So be sure to check it out. And we will also email everything out to all of you that way as well. Looks like we have a couple more questions coming in. Trying to work with major research organizations. When this was proposed several years ago, it was blocked by one of these organizations. More of a comment, I'm sorry about that. We also have a comment here from Tony. CMS has proposed the inclusion of organs intended for research and allocating organ acquisition costs for OPOs. Are they referring to the allocation of direct organ acquisition costs now allocated on intending for transplant programs, organ acquisition overhead costs, let's see, now allocated on intended for transplant programs, and allocation of total kidney costs based on usable organs, which is currently excludes kidneys intended for research. Seems like CMS.
Yeah, so it is, you're absolutely right, and it is completely inconsistent. When you look through one area of it, you think, oh yeah, that's okay, it's covered, and then you go to the end and you find that it's not. So there's a lot of clarity needed. And the other thing to bear in mind is there's no guidance document with this. So we really are, left to somewhat interpret this ourselves.
Brigitte, there was a comment earlier in the running comments about touching on the impact of children's hospitals that perform transplant. I just wonder if you might review that again briefly.
Sure. I mean, overall I think there were about 25 children's hospitals that filed their own cost reports, and the resultant losses in the analysis was about $24 million. I actually have a call tomorrow with the Children's Hospital Association to go over this in more detail and strategize how we might be able to bring some comments to the forefront through them as well. But I think, as we know, many less children have Medicare. And so for years, the children's hospitals have gotten some help from being able to get that Medicare funding for those organs that they procure from their hospitals. And so it has this disproportionate effect on them. Okay. And I actually, Jennifer, I also see too from Linda reiterating that the comments are due by June 28th. And I think one of us might have said July 28th by accident. So it's June 28th, 14 days. 14
days.
Yeah.
And Kevin O'Connor also posted a link to ASTS has provided a template letter that can be used. And it's pretty easy. You really do just click the button, link is there to submit your formal comment. It's been stressed to us that quantity of letters and public comments is absolutely as important as the strength of your organization or the perfect letter. And what we know, just like we do an OPTN public policy, is you often go right to those public comments and you start reading it as you formulate your own. So I can't encourage you more to get a letter in. based on the information you heard today, and you'll certainly see those sample letters after when the recording's posted.
Thanks, Jennifer. We have another question here. I'm not sure if we can answer this. We can ask CMS to postpone any rulemaking until they study this further, but at the end of the day, implementation of this rule is a significant loss to transplant. Do you have any suggestions on how we can convince CMS not to change the formula at all?
I will say from every meeting I've had since Austin Williams first sent me this email, what I've been encouraged to do is stress to call for a delay. Right. Medicare makes some very strong points, as I mentioned earlier, and that is that they should share the burden of these costs with private payers. And so I think that a study, calling for a delay in a study, has been very powerful in the past when Medicare has made proposed changes, and the results of that study are generally multi-society, multiple stakeholders are engaged. So I don't, from everything I've heard, Brigitte and Helen may feel otherwise, is that we will not have success if we simply state, don't change it, but instead point out to Medicare where they failed to understand the impact and where that impact needs to be studied.
I agree 100%.
Yeah. You know, it's sad to have come this far and realize that CMS, certainly on the financial side, still has no understanding of how OPOs really work and the connection between us and our transplant colleagues to save lives.
And there was a comment, Suzanne Respis, I couldn't agree with you more, Suzanne. She said, when you do submit your letter, your organization submits a public comment, copy your US senators and House members on the comments you send. They should get a copy of your comments. Thank you so much for pointing that out. I'll adopt that language as I move forward and advocate. And and as Deanna pointed out at the beginning, we really wanted to present a fair overview of the proposed changes. And so that would include those of you that are supportive of Medicare's changes. Everyone's voice should be heard, and the public comment period is open to all.
Just giving a couple minutes here, see if we have any last minute questions. Not seeing anything come in. So with that, I do just want to, on behalf of the Alliance, I want to thank the three of you ladies so much for taking the time to join us today and share all of your insights. I really appreciate the high level overview that you provided to us. And I think just based on the comments and the variety of questions that came in, it certainly is something that was timely and of need within the community. So thank you again for bringing this to the Alliance team. We're so happy that we were able to provide this forum and this opportunity for such an important discussion. So thank you ladies so much. And to all of you that joined us today, we hope you found this presentation to be valuable. I can see just based on some of the comments coming in here, a huge thanks to all of you ladies coming in. So thank you once again. We really appreciate it. And again, be sure to check out the community resource toolbox on our website at organdonationalliance.org. All the resources that have been requested and shared with you today will be posted there. And we will certainly be in touch with all of you via email to share them there as well. So thank you all so much for joining us, and we'll see you again in the future. Bye, everyone.